Should we give everyone a couple of minutes to transition, or should I get going?
It's completely up to you. It's 10 o'clock, so if you'd like to start now, you can, or if you'd like to give it a couple minutes, you may also do that.
Okay. I think there's quite a bit of people jumping off another meeting here, so let's just give them like 1 or 2 minutes. Okay, I think we could probably just get going. Good morning, everyone. I'm just doing a sound check. Can people hear me?
I can hear you.
Yes.
Okay. We're going to do a quick review of kind of how to triage or think about conductive hearing loss. It's going to be a relatively short presentation, and then we can go over some audiograms at the end if we have enough time. So I'm one of the otologists at Emory, and welcome to everyone who is able to join this morning. We're going to start off with just going over some of the basics of what we'll call the Tympanosclerosis system. And again, conductive hearing loss is predominantly a mechanical issue, right? And so thinking about it in those ways can be very helpful. But then there are a few things that will dupe you that are not really mechanical, but more physiologic. And so we're going to try to build a little bit on that distinction and how to organize those thoughts in your head as you're evaluating these patients. So the point of the ossicular system is to couple air and fluid discrepancies and transport that mechanical energy. The energy is a result of transformers within the middle ear and the inner ear mechanism. So there's important things to kind of remember. There is a surface area ratio between the tympanic membrane and the footplate that's about 20:1. And that helps kind of transform energy in that regard. But then there's also 3 different lever systems that we can think of within the middle ear itself. The catenary lever, which is involving the tympanic membrane, the ossicles, and then the hydraulic lever, which is the interface with the inner ear. Theoretically, there should be about 34 decibel gain in this system, but the actual gain is only about 20 to 25 decibels. We look at the malleoinguinal joint first. It's composed of hyaline and synovial, hyaline cartilage that is, and the synovial fluid. And initially at low frequencies, it's more of like a hinge-like motion, but as the frequencies rise, it turns into more of a twisting motion. So that's kind of interesting. It can, depending on how much energy is going through, it could either do this or then turn into more of this motion. If we think about the incudostapedial joint, this is a diarthrodial joint. It also has hyaline cartilage and synovial fluid, but also has a fibrous meniscus. And the joint capsule encompasses the entire lenticular process, and it has some elastic fibers. So when you think about if you have been involved with Stapes surgery at first, it's not very easy to transect that joint because there's multiple different layers at that level. And when you're using a joint knife, you really have to twist and try to get through those multiple layers. So it's typically a pretty sturdy layer. So that's the fundamentals of the ossicular chain. So let's go into some of the differentials of conductive hearing loss that should be in all of our minds. Not necessarily the most common, right? But it's something that should be in the differential, and certainly things that you will be tested on. The first one that has gotten a lot more attention over the last, decade or so is a pseudoconductive hearing loss that is really a consequence of a superior canal dehiscence and what we call this third window effect. So we'll go a little bit into what that means. The normal inner ear function is an enclosed system of bone, and that bone is obviously non-compressible or pliable, and it's actually the densest bone in the body. But within the inner ear, you have multiple different fluid compartments, and within the semicircular canals, you have constant motion of fluid, and what happens is, as you can see in this illustration that we have here, as the mechanical motion from the outer ear goes into the middle ear and it vibrates the ossicle, ending in the stapes, that motion, that in and out motion, gets transmitted through the cochlea, as it's seen in the arrows, and eventually there's the outward motion of the round window. Again, when you perform Stapes surgery, it's not unusual to check for a round window reflex. That really is an integrity check for this particular route of energy that we're seeing here. Typically, if you palpate the stapes, you will see an outward motion of the round window. And after you do your stapedectomy, you can check for good position of your prosthesis by verifying the round window reflex. Not always possible. Sometimes that angle of the round window is not clearly visible, but whenever available, it's a good check. With the superior canal dehiscence, we're introducing a third window. That means that some of the egress of energy is not just from the round window, but potentially either at the superior semicircular canal, or sometimes there are also fistulas into the semicircular canals from superior petrosal vein or other pathologies. But in essence, it means that you're losing some of that energy, that hydraulic energy, through a third mobile window. So what happens? This is what I was explaining in a little bit more of a schematic form. The exposed membranous canal can be in any number of different locations. The most common one is going to be at the very apex of that superior canal where there's bony deficiencies. It can be focal or multifocal, and again, it could also involve not just the superior canal, but it can involve one of the other semicircular canals, whether it's from a congenital erosion from a vein, or potentially from infectious chronic ear issues such as seen with cholesteatoma. In these situations, what would happen is, if you were to perform a round window reflex check, whether it is in preparation for middle ear surgery, you would see that no matter how much force, torque you put in the IS joint, you may not necessarily see the reflex. Or if you're palpating the foot plate, you won't see that reflex of the round window. And it's one of the thoughts of how there were people, many years ago that were undergoing stapedectomy surgery, for example, and they would go through the procedure and then not perceive any improvement in their conductive loss. Well, now we're much more smart about that, and we're going to go through what are some of the key indicators that can help avoid that problem. Because of the pathology of a fistula or a third window effect and the inner ear mechanism, there is decreased bone sensitivity, meaning that patients tend to have a perception of sound at much lower magnitudes. You can think of it that way. So that is translated into very, very low bone conduction thresholds on an audiogram. So how can you be fooled? The superior canal dehiscence can have audiometric patterns that are visible as air bone gaps. Again, mostly because that bone conduction line is going to come in at 0 or between 0 and 5 decibels instead of matching with the air bone gap. And sometimes they won't have necessarily any sort of vestibular symptoms, but nowadays we always query patients on those symptoms. But just know that not everyone with a radiographic deficiency of the superior canal or one of the semicircular canals are going to have any vestibular symptoms. The incidence in our institution of having, idiopathic, or rather asymptomatic superior canal dehiscence has been, we did a study and it was about 30% where you can find a bony deficiency without having any sort of symptoms. So it was just an incidental finding. But the oral symptoms, they can have other symptoms, not just vestibular symptoms, but they can have some fullness, some autophony, pulsations in the ear can be present or absent. But it's good to just kind of go through these things in a patient you're first evaluating for a conductive hearing loss, just to get an overall big picture. So what are some of the clues? The clues that this is not really otosclerosis, but potentially a superior canal dehiscence is by looking at your acoustic reflexes or your stapedial reflexes. This is a necessity for anyone that is undergoing an evaluation of a conductive loss. And some places may not perform them, but I think most academic centers do, but it is an essential part. When you have acoustic reflexes present in the setting of a conductive loss, that is a real big clue that this is not an ossicular malfunction, such as with otosclerosis or ossicular erosion, but that it is very much likely possibly a superior canal or just a third window effect. So that is really one of the most important takeaway points for this particular differential. If you're evaluating conductive loss and you have acoustic reflexes present in that ear, that means it is not otosclerosis. So always make sure that your audiologists are providing you with those reflex testings whenever you see a conductive loss. Do a review of the typical symptoms that we see with canal dehiscence, just like we talked about, sign-induced dizziness, autophony, pulsations in the ear, but realize that not every patient that has a true third window is going to have symptoms. A lot of them are asymptomatic. Most of them are actually asymptomatic. If you see a bone threshold that is at 0 or near 0, that should raise a red flag. VEMPs are often used when we're trying to determine if a patient has symptoms related to the superior canal dehiscence. What we see in these patients is that the VEMP thresholds are much more sensitive. That means they're lower. It's easier to trigger a VEMP reflex in patients who have superior canal dehiscence. And that is a very helpful test when we are trying to determine whether surgery should be offered to those patients. Again, that's for another topic, but it is something that can be a tool in your toolbox. And of course, the gold standard is to get CT imaging with thin cuts and reformatted images through the canals themselves. And that is really the standard for diagnosing the presence of a canal deficiency or dehiscence. So these are some representative pictures of, I'm sure many of you have already seen pictures of this kind. These are reformatted And you can see with the arrow where there is a bone deficiency over this particular patient's superior canal. And so again, it could be multifocal, it can be focal, it can be present in one or both ears. This is an example of VEMS in patients, in a patient with a canal dehiscence. The threshold is, it's hard to see here, I apologize, but what we're trying to show here is that it's much easier to elicit a response in patients who have a canal dehiscence. So just remember, that's kind of the main takeaway point, that your ear is just much more sensitive. And so it's much easier to obtain those thresholds compared to non-canal deficient, canal dehiscence ears. So moving on to the next differential is an enlarged vestibular aqueduct. What we're showing you here is a very abnormal vestibular aqueduct, and with the black arrow. One of the ways that our radiologist likes to compare them is to get the plane of the posterior canal and with the vestibular aqueduct, and it should be about the same size. Some are mild, some are very abnormal, as is shown here, meaning some are very easy to detect, whereas others don't. And so this is one of the formulas out there that you can use to officially diagnose an enlarged vestibular aqueduct. And some of the takeaways with this is that the midpoint width of the vestibular aqueduct is most predictive of a progressive hearing loss. If you have already a mixed hearing loss in the lower frequencies, and then that means that you're most likely to progress the hearing loss over time. Some of the issues with enlarged vestibular aqueduct is, what you tell patients in terms of restricting activity, particularly troublesome or difficult to navigate in children or young adults when you're restricting their activities. I think most people agree to avoid high impact contact sports like football and tackling. But in terms of other activity, I think it's really between the provider and the patients in having a risk benefit assessment between restriction and having more of a normal social activities and exercise activities. Another one, X-linked Stapes gusher syndrome, and it's it's basically an enlarged communication between the subarachnoid and paralymphatic space. Typically progresses into a mixed hearing loss, and the timelines for progression of hearing loss is really variable. We see patients that develop the hearing loss very early on, whereas I still see adult patients that have progressed in the hearing loss much later in decades. So 30, 40, 50th decade of life, they still have some progression, and some of these patients end up even qualifying for cochlear implants as adults. In general, stapedectomy for this condition is not very successful, so we try to avoid it, particularly in younger folks. You have a significant risk for having a sensorineural hearing loss when performing surgery, Stapes surgery for this particular syndrome. So we try to defer that in younger individuals. What are some of the radiologic findings, things that should really alert you that this is not routine? Otosclerosis, definitely age. These patients tend to present earlier in life, and so sometimes that could be a clue in itself. But if you get routine imaging, which many people do, especially in younger or atypical patients, you're going to see that you have more normal cochlear outer walls, but you have an absent and bony spiral laminas, which are reflected here with the arrow and the star. And so there is an absent bony septum between the cochlea and the internal auditory canal. And there may also be a dilation of the fundus, of the actual fundus of the internal auditory canal. The labyrinthine fallopian canal can be also enlarged. So that's where your facial nerve is exiting the internal auditory canal. So these are all clues that you can look at in academic institutions. Neuroradiologists typically pick up on these, or in your pediatric hospitals. But if you're in a smaller rural community, these findings can be subtle. And so it's always a good idea to know about them, and for the surgeons to be able or comfortable to look at these inner ear radiographic images and be alerted to any atypical findings. So it's very important as otolaryngologists to become very familiar with the CT findings of a normal temporal bone, so that when you see something that doesn't look quite right, you can either ask your radiologist for help or certainly refer those patients to someone that may be more comfortable with that particular pathology. As mentioned earlier, the outcomes for stapedectomy and X-linked gusher syndrome they're relatively poor, and you have a significant incidence of a profound hearing loss. And so we defer surgery in those patients. We really encourage hearing aids, and eventually they progress to cochlear implants, typically later in life. CSF leaks, insertions into the IAC with a cochlear implant surgery are real complications that you have to be aware of. I'm sorry for the typo there. And there have been plenty of those that have been reported over the years. And sometimes if it's significant connection between the IAC and the cochlea, you may need to do some of these with fluoroscopic guidance. So that's something to keep in mind. Moving on to some ossicular abnormalities. You know, this is a typical audiogram, and what we're seeing here is, you know, if we were live, I'd be asking you to describe this, so I'll just do it for you guys. We're seeing a mild sensory or hearing loss in the high frequencies in the right side. However, on the left, we have a conductive loss. It is not a mixed hearing loss, which is something that I really like to highlight for residents, because it's something that comes up in your boards and when you get tested on, differentiating between a mixed and a conductive loss. A mixed hearing loss infers that you have an underlying sensorineural loss, meaning your bone line is not in the normal range. So in this patient, we have a purely conductive loss. The fact that there are these squares on the left ear is significant because it says that the audiologist was masking the air thresholds, which is very important because you run into masking dilemmas when there's a big asymmetry between ears. And that's something that we all have to learn to try and identify in audiograms. And typically we do that by confirming these sorts of losses with a tuning fork. In this situation, a tuning fork placed anywhere along the midline would defer the sound to be loudest to the left ear, which is what we call the Weber lateralizing to the left. In this level of conductive loss, you'd also expect the Rene test to be bone greater than air. And so sometimes we run into nomenclature issues, Rene negative, positive. So what I tell our residents is just describe, if you're not really sure, instead of saying negative or positive and potentially reporting the wrong thing, just describe what the patient said. So bone greater than air. So in terms of the ossicles themselves, if you have, some of the things that you can think about is if you have, in terms of predicting the degree of hearing loss and how it correlates to what could be going on in the ossicles, an intact, tympanic membrane with some sort of ossicular disjunction, whether it's erosion, dislocation, or otosclerosis, tympanosclerosis, is that even if you have an intact tympanic membrane, you can have a maximum conductive loss if your ossicles aren't working, right? So that could be a maximal loss. And if you have an incomplete ossicular disjunction, so just maybe a weak joint, fibrous band, scar tissue, maybe a little bit of tympanosclerosis that hasn't totally fixed the ossicles, you can have ear bone gaps that are under 50 decibels. Maximum conductive loss is about 60 decibels. So think about it that way. Between 50 and 60 decibels is what we call a maximum conductive loss. So what are some of the differential diagnoses when we're thinking about something wrong, inherently wrong just with the ossicles? We can have necrosis of the incus. The lenticular process of the incus is the skinniest and has been shown to have potentially the least vascular supply, and that's why it could result in necrosis. You can have Stapes fracture, dislocation. It could be from trauma. You know, we see a lot of Q-tip trauma or even negative pressure trauma that people with tight earbuds and pull the earbuds out and suddenly have a hearing loss. They can undergo a fracture or dislocation just from that, and I have seen that several times. You can have a congenital malformation. You can have a lateral chain fixation as a very common example of a congenital malformation. And then you, of course, all kinds of different traumatic injuries, whether it's blunt trauma or direct trauma with a foreign object. So key things, you know, you have to become comfortable in otology. Everyone in otology clinic has to use the microscope. It's very important to get comfortable with it. It's like night and day comparing otoscopy with your actual microscope exam. You have to learn to use your pneumatic otoscopy or pneumatic massage to look at the actual movement of the the tympanic membrane. You can learn to evaluate your acoustic reflexes, or at least always have that in mind. Look at your CT scan if you need to, if it's an atypical patient or if it's someone with more of a chronic ear disease or some other red flag that prompts you to get a CAT scan. Not everyone gets a CAT scan, but oftentimes it is part of our diagnostic workup. And your tuning forks, right? Your tuning forks are very important. You have to get comfortable. Everyone in otology clinic with us, no matter what, just gets a tuning fork exam because it's one way to get really proficient at it. And there are nuances about tuning forks that you learn over time. So it's really important to just do it on every patient in your otology clinic to get comfortable. One of the things that can be, you know, sometimes we see patients with a lot of scarring. You know, you'll get referrals from primary care docs who see an abnormal ear exam, as you see here, and they worry and they send the patients. Most of the time, laryngosclerosis, which is what this picture is showing, is not necessarily going to give you any problems. However, the tympanosclerosis, middle ear plaques will, and that's just something that you should keep in mind, particularly in patients who have had a lot of ear infections in their youth. And, you know, it's thought that these calcifications build up as a consequence of infection over time. You know, whether it's truly an inflammatory process or byproduct of just infections, we don't really know, but we believe those patients have had a history of chronic ear disease. But it can really lead to a complete fixation of the ossicles at times. That can be pretty impressive. Sometimes you just see small focus of tympanosclerosis, and other times it's much more diffuse disease that you cannot manage surgically in a safe manner in those patients. You know, you'll defer for hearing aid or some alternate means of amplification. Interestingly, sometimes it looks very diffuse and the hearing loss may not be reflective of that. And other times, you know, it could be small foci that could be a strategic position, such as around the foot plate or in certain parts of the joint that give you a more severe hearing loss than you would expect for what you're visually seeing or palpating. When you are performing you've got like a surgical exploration for conductive loss, and you've kind of gone through your preoperative list of differential things to particularly look at when you're in the middle ear and you look at the anterior ligament of the malleus. Sometimes that's calcified. Sometimes that's an area of fixed lateral chain fixation. That's a congenital fixation. The MI joint, the stapes in the pyramidal process, and then of course the round window niche. So these are all specific areas that you should be able to evaluate when you're taking someone to the operating room to address a conductive loss. For stapes and other middle ear work, you have multiple different options. There's a multitude of ossicular prostheses, whether they're partial, total. You can use lasers, you can use drills. It really depends on where you train, how comfortable you are with specific technology. But there are a multitude of different options out there depending on the pathology. So just to conclude this part is that there are many etiologies for conductive loss other than otosclerosis, even though that is by far still the most common with a normal ear exam. And the differential is reliant on having a proper exam, an audiogram that includes your acoustic reflexes, the imaging and vamp testing when appropriate. Sometimes audiometric patterns can give you a clue. And so having a good idea what the diagnosis before surgery really obviously improves your outcomes, but always be prepared to have surprises. Sometimes you find things unexpectedly. And so if you are not the most well-versed middle ear surgeon and you find yourself in a bit of an unusual situation, sometimes the safest thing to do is just close up and refer that patient to someone who may be performing more routine middle ear reconstructions. And you know when to not to operate, right? And so there are patients who have only one good hearing ear. One of the key things is don't operate in the better hearing ear. If it's a very fragile patient, you don't want to take someone to the operating room when they can potentially have risks from a surgical intervention, when you can just give them a hearing aid or talk about some other conductive bone conduction, rather hearing amplification device. Now there are not just surgical bone conduction devices, but there are some that can be worn in bands, and even for adults. So those are the main takeaways. I believe we have an hour. So the next part, I was gonna hope to just go through some audiograms. The residents at Emory really like going through audiograms, and it looks like there's over 50 of you. So what I would like to do in this next phase is I'll pull up a couple of different audiograms, and I'm gonna ask people to just send me a message and tell me what you think, how you would describe that audiogram, whether it's sensorineural, conductive, mixed, which ear. And that usually is a little bit more interactive and more fun than just listen to someone for an hour. So I'm gonna pause my share for a sec here while I get the other screen. Okay. All right, can you guys see this now? You can, let's start using the chat function. Do we have the chat function available?
Yes, the chat function is available.
All right. So this will be a little tricky, but let's give it a shot. Again, just send, you can just send a message to everyone using the chat and just chime in, and I'll go along as time allows. So how, if there are any PGY1 or 2s out there, we'll start off with you guys. How would you describe this hearing test? Just start typing away. And I want you to go through the different components of it. So is this a normal, abnormal exam? Anyone? Okay, bilateral high frequency sensor neural loss, good. Are there any red flags in this test? Anything that is worrisome, or what would be the most likely diagnosis in this person? Let's say it's a 55-year-old male. Exactly. Presbycusis versus noise exposure. Okay. Certainly top 2 in that age group. I would say this is a pretty routine finding of presbycusis. You can see that your tympanograms are A, which is normal. Your clarity is pretty excellent. In this particular test, the audiologist masked, not necessarily when it's so symmetric, but they're being very thorough. And I would say this is a slam dunk presbycusis. Very good. So how about this? Tell me, is this what kind of hearing loss is this? How would you describe it? Try not to look at the very bottom. It's kind of cheating. All right. So profound mixed loss. So this is, thank you for saying that, Jay. So at first glance, you would say, yeah, this is a mixed loss, right? But one of the things that is really a key learning point for this particular audiogram is that beyond 60 decibels, you can't really, you lose the integrity of your bone conduction, because at 60 decibels or above, the sound transfers to your other ear. And so you can't really mask between ears at 60 decibels. And so what those little arrows are showing is that this loss is beyond the bone conduction thresholds that they can reliably measure. So in essence, this is really a sensor neural loss, but they're showing you the bone lines that bone lines maxed out at this point. So this can be used on your boards and other tests to really throw you off, because they'll ask you, hey, is this a mixed hearing loss or is it a sensor neural loss? And what the arrows are saying is that there was no response at the maximum level that the bone conduction oscillator could go. So that's a really important key point. This is not someone you would offer any sort of middle ear intervention. You know, sometimes there's a role for offering surgery to improve the threshold so that hearing aids don't have to be as powerful. And people can really fall into a trap in these particular situations, because they can say, oh, it's a mixed loss. Maybe I can give them 10, 15, 20 decibels to gain. And when in reality, it's all sensor neural. So that's a really important takeaway point here. All right, so what do we have here? This is a little bit more of a thorough exam. Couple, you know, now we have some reflex testing here. So what would you describe this as? What is a big red flag here from what we talked about today? Exactly. That's the first red flag, the suprathreshold bone lines in both ears. So now we have a suprathreshold bone line in both ears. Look at this, it's at 0, and this one is off the charts almost. We have an air bone gap, right? Air line, air bone gaps. The left ear seems to be more affected than the right, but what are we seeing? Is this from fluid? Do you think this person has a tube or fluid in the ear? Well, for that, you go over to your tympanogram. And your tympanogram is saying, hey, no, the eardrums are moving exactly, type A TIMS. The eardrums are moving fine, so it's not from a perforation and it's not from fluid. And so that's kind of makes you think twice, right? Like, what's going on here? Well, luckily our audiologist did perform the reflex testing. And what you know, one of the ways to cheat this is if there's a number there, that means there was some measurable reflex. If all you see is NR, no response, that's when you get, that's when it's more consistent with the middle ear pathology, right? But the fact that you have numbers here, whether it's 90, 95, 100, don't get so caught up initially in the actual, what the actual number means. But if they're numbers in general, that means there were reflexes present. And they check them at different points of the frequency range. And the fact that this is a conductive hearing loss, supposedly, with type A TIMS and acoustic reflexes present, this is not going to be otosclerosis. This is not going to be an ossicular malfunction. And so we are thinking this is probably a consequence of a canal dehiscence. Exactly, you guys are saying it right there. So important takeaway points. Look at your tympanogram, so there's a conductive loss, right? Take a look at reflex testing. If the reflex testing isn't there, just ask your audiologist to perform it, but also be really in tune with your exam, the mobility of the eardrum, and your tuning forks. So could it be that this person has bilateral superior canal dehiscence? Yep, it could be. Does it mean that they have superior canal dehiscence syndrome? Not necessarily. It could be that, again, the bone deficiencies are there present much more often than they're symptomatic. So you're not going to offer a patient surgery to improve the hearing. That's a very important distinction about canal dehiscence pseudoconductive loss, is that you don't operate for the hearing loss, you operate for the vestibular symptoms. So that's really, really important to keep in mind. Let's see. Oh, this is good. All right. So who wants to, maybe a higher level PGY can take this one on. It's a little bit more complex. There's a few new terms here that are important to point out. So if there are any 3s, 4s, even 5s out there, why don't you give it a shot? No takers? Come on, guys. We're almost done. Okay. Mixed loss on the right. Okay. Profound on the left. Okay, good. All right. Very good. So let's take one of those at a time. Let's start off with, is this really a mixed hearing loss? Let's start off with some of the nomenclature that the audiologist, they're putting a lot of things here, the audiologist, is that we typically don't see. So let's start off with these bone lines, okay? Now, the bone lines that we're offering for the left ear, so always remember when the bracket is opening to the left is the left ear, if it's opening to the right is the right ear. Usually you have a key here, but if you don't, that's a very easy way to remember it. So the bone lines for the left ear are giving you that funny looking arrow at the bottom. What does that arrow mean? that means that there was no response. So don't get fooled by that. It's kind of like the other audiogram we saw earlier. When you see an arrow coming off of a bone line, that means that there was no response. The audiologist tried to test it at those particular levels, but there was no response at all. So this is in fact, and the same thing goes with the air thresholds. So these, as you can see, they masked this left ear, which is the appropriate thing to do, but there were no responses. So this is in fact correct. It is a profound hearing loss. The right ear is tricky because now we're getting some bone lines here. And these bone lines have a little asterisk on them. That means that they're having a very hard time masking this asymmetry, because the asymmetry is so large that if you make things loud enough on the left, you're going to hear it on the right, and back and forth. And so this is a masking dilemma. All right, and masking dilemmas come up on your boards and your in-service. It's hard to sometimes describe in words, but if you just think of it in a more kind of conventional, like everyday thing, is like, as I said earlier, if one ear is deaf and or near deaf, and you're trying to test the levels at which this can actually hear, if you keep making things loud enough, the sound's gonna transfer to your other ear and you may get a response from the patient, even if you're masking this ear. And so it's at a certain point, even if you're masking, the sound is so loud when they're that asymmetric that it's very hard to differentiate ears. And that is a masking dilemma. So what it's saying here is, you know, we're getting quite a bit of a dilemma differentiating right from left. We have a profound loss on the left ear. The right ear is, you know, saying, hey, you know, this could be an ear bone gap. And guess what? We do have a type B tympanogram. So maybe is that fluid or is it a perforation? Well, in that case, the next part you start to use is the volume. So volumes of, I would say, over 1.5 or 2 is abnormal. It really depends on the caliber of the external auditory canal. A volume of 5 is definitely abnormal. That means there is a hole or there is a tube. So this patient is in bad shape. They have a deaf left ear. They have a right ear with predominantly sensorineural loss with a little bit of a conductive component. So they do have a mixed hearing loss. So this is really a complex audiogram to navigate. Up here, if you look at your speech testing, they couldn't even test the left ear. That's what it means. CNT could not test because it was a profound loss. And what they do is SAT, so it's sound awareness threshold. So they can't test your speech reception threshold, and if you cannot, you know, if you're that profoundly impaired. But sometimes they can just tell you at what level can they get a little bit of a sound awareness. And this patient only got sound awareness when they got to 95 decibels, which is a very loud sound exposure. So we'll stop there. We have about 10 minutes, 5 minutes, 5-10 minutes of questions. So if you guys have anything, just go ahead and speak or send a chat message, and we'll go from there. Okay, nothing's coming through. So we'll end a few minutes early so people can have time to get a coffee or a drink or just stretch out. Thank you again. I'll see you guys again, I believe, on Friday. We're going to talk about imaging characteristics of intracranial hypertension and CSF leaks. And so I think that would be also very interesting. Lots of pictures to go through. So that'll be kind of interesting. Have a good day, everyone. Thanks for joining.
Thank you.